is not clear this time. So we will go through the International Patient Safety Goal number 2. And this is one of the major part in whole this webinar, because this is the most important IPSG that there is a high percentage of error and high percentage of incident. And this is not from me, this is from Joint Commission review, total of 936 sentinel events during the year 2015. And communication was the root cause of the more than 70% of the serious medical error. So communication is one of the leading cause of sentinel events. And it is very important to have this information that communication is not one-way loop. So not a sender and receiver only. The communication, we need to have this closed feedback loop also. So the sender and then there is a receiver, but on the same time need a confirmation. So again, the receiver will send to the sender. So it will be like a feedback loop. So this is a closed loop communication that we need to enhance in our practice. Let us go to the examples about error-prone communications and approved abbreviations. So communication, not only verbal communication, can be written communication, endorsement, verbal order, telephone order, and critical result over the telephone. So how this communication breakdown can lead to sentinel event or patient safety events. Let us go to the unapproved abbreviation. There is one of the common posts. Every organization is very important to have a list of unapproved or prohibited abbreviations. And if you are using electronic medical record, also you have the system that help you to not utilize such kind of unapproved abbreviations. So if you go through this article from Joint Commission, let us give an example about unapproved abbreviation. So IU, which stands for International Unit, but can be mistakenly because of the handwriting as IV, or number 10 because it's close to 10, so it is IU. So that's why when you want to write International Unit, it's should be written without unapproved abbreviations. For example, another common one, like obstetrician will say about cesarean section CS. But for the microbiologist, CS mean culture and sensitivity. So it's very important to avoid such kind of unapproved abbreviation. And the hospital has to have a very solid and strong system that to prohibit the use of unapproved abbreviation. And like many times we said, OD, QD, O can be mistakenly by Q. So all these can lead to medication error and harm to the patient as well. Number 2, regarding the endorsement. Endorsement is a very, what we can say, error-prone communication type, because this is a lot of teams. You have like physician endorsement, nursing endorsement, multidisciplinary team. Sometimes you have 2 shifts, sometimes you have 3 shifts. So every time that whenever there is a more process, there is a more chance of error and more chance of lapse and misinformation or misdata, or sometimes wrong information exchange. So in order to avoid this, there are many organizations propose or adopt an endorsement or structured standardized endorsement tools. One of the tools that is well validated by Joint Commission, AHRQ, IHI, WHO, considered the SBAR tool as an effective, validated, reliable communication tool for patient handoff. And as well, it is recommended in SBAHI standard, the similar tool. It is proved to reduce hospital adverse event, improve healthcare provider communication, as well as patient safety. You will find this article published in 2018 with the full detail about the validation and how it's reliable and how can prevent such incidents. So ISBAR, so they said instead of some doing endorsement verbal, some doing written endorsement, some fine, but at least that you have a structured process. What is the information need to be delivered during the endorsement? So you will hide acronym ISBAR. So S stand for situation of the patient, B background, A your assessment, and then R the recommendation. And it is very important to mention what is the recommendation. For example, you give a blood transfusion for a patient, your shift is finished. Very important to, in your recommendation, kindly follow the CBC result after the transfusion. So this kind of information need to be delivered to the next team, because not every single information is clear to the coming shift. So each organization need to have a structured way of endorsement communicated, and then not every department has its own way of endorsement. It's rather to be systematic, structured way in order to avoid such human error and forgetfulness and sometimes unintentional loss of information. Okay. Regarding the verbal order, actually, verbal order means it is an order for a specific patient given verbally to authorize staff to be carried out before the order countersigned by ordering practitioner. And due to safety concern, Joint Commission and other advocate for limiting or ending their use. So actually, most of the organization try to avoid such kind of verbal orders. And this is usually limited during coding or sterile procedure. Coding, that means if there is a CPR or during a code in emergency situation, so at that time, the physician allowed to give an order and the nurse will carry on the order, although it is not signed by him during the moment of the code. But immediately once the code finished, the physician will sign every single order that he ordered during the resuscitation or during the coding. Similarly, for the procedurists, for example, they have endoscopy or cardiac cath. During endoscopy, while the physician busy in doing the procedure, so at that time, there will be verbal order to give certain kind of medication. The nurse can be carried out, provided that after the procedure, everything documented and signed. Otherwise, no verbal order allowed for any during walk round or any routine round. Any medication you want to deliver to patient should be documented in the file. Nothing will be like verbal order except in emergency or life-saving situation like I mentioned just now. Number 3, regarding the telephone order. It's a similar concept as verbal order, but the only difference between the verbal and telephone order, this will happen usually if the physician or the ordering practitioner in a place remote to the patient site. So maybe the surgeon or the physician, he's in operating room or an emergency department and something happened in the ward. And he is far away from and the situation mandate to give a telephone order. So this each hospital has have a protocol for dealing with telephone order, and when the physician, after finishing his part, he should come and countersign whatever he wrote. But again, this kind of situation need to have like witness with you to call somebody else and to clarify the order before giving, because this is a kind of communication that can be also the information can be relied wrongly or perceived it wrongly. Whatever the situation, verbal or telephone, should be minimized as much as we can, because these are kind of error-prone communication that can be lead to patient safety events. Lastly, but not the least, the critical result over the relying critical result over the phone. Just to address for the few, if critical result meaning is not clear, for example, that the result usually laboratory or radiology investigation that mandate physician intervention or timely intervention. If not done on that time, we might the patient life will be jeopardized. For example, you find a hemoglobin suddenly 3 for one patient. So this is critical result need to be relied and on timely manner. So the take an action. For example, potassium 7, the patient can win to arrhythmia and arrest. So these are the critical results that need to be, there need an urgent intervention and timely information reaching to the physician or to take an action, for example, or tension pneumothorax. So whatever the critical result, there is standard policy about the critical result in each hospital. There are protocol for the critical result. Before going to the protocol, if you see this picture, this is a waiter in the restaurant. Whenever you are going to the restaurant, you will find the waiters start to write down your order. And then what she will do, he will do, he will read back the written order. And then you confirm this is the order that you ordered. So this is, 3 steps closed loop communication done in restaurant, and it's not a life-saving, and it's just for satisfaction of the customers. So it's really our right also to have our practice to be delivered in a way that we are saving patient lives. So the critical result follow the same protocol. You will receive, whenever you receive a call from laboratory technician, for example, you need to have to write down what is the information that they write. This is one of the example. This pink form is one of the organization utilizing it for writing down any critical result available in the desktop or in a very near place from the telephone. So whenever there is a message that critical result announcement, and then the receiver, after he write down, he will read back the order. Not repeat back, read back. That means he write it and then he is reading it. And then lastly, the sender, the individual who gave the order, he will confirm that he has been written and read back is accurate information. So this is how, when you are relying critical result over the telephone. And this is from examples about error-prone communications that can happen. Dr. Habib, can you share with us case scenarios?
Yeah, sure. Waiting for the next slide to load. Yeah, I will share with you 3 beautiful examples of things which went wrong so that we learn from them. So this was a case report of a 72-year-old man was admitted in hospital with community-acquired pneumonia and hyponatremia. During his 3rd hospital day of stay, the on-call physician was immediately contacted by the charge nurse because the nurse had received a critical panic value. For potassium, it was 2.2. The physician immediately came to the ward and started writing the management. While writing the management, the physician thought, let me see, because he's on call, he doesn't know this patient. So let me see the electronic health record of this patient to see what was the previous potassium level. And to his surprise, he found that there was no order to do a potassium level for this patient. And when he checked the nursing notes, he found that no sample was taken for this patient and sent to the lab to do a potassium. Then when the matter was escalated and when they dug in more, they found out that the critical value was actually not for this patient, but it was meant for another patient on the same unit, but with a different last name, with a similar last name, but with different first name and different file number. It was never known whether a readback actually happened. Next story. This is another very worrisome incident. This was an 81-year-old female patient who was on warfarin. She suddenly developed asymptomatic runs of VTAC while hospitalized. The unit nurse immediately contacted the physician, who was actually engaged in a sterile procedure in the cardiac cath lab and could not come physically to write the order. So on the phone, he instructed the nurse, please give this patient 40 of K. The unit nurse, who so happened that on that day she was pulled out from the NICU, and she was actually not a full-fledged nurse in the adult ward. She was in the NICU, and on that day, for staffing shortage, she was pulled out. When she heard this 40 of K on the telephone, She wrote down in her notes, give 40 milligrams vitamin K IV now. The reason that she wrote this down is because if you work in the neonatal ICU, the only K that we know there in the NICU is vitamin K, and that's the only K that we give to the patient. We do not give any other K to the patient. The unit nurse then went and took the vitamin K and administered 40 milligrams of vitamin K IV to the patient. The actual order was supposed to be 40 milliequivalents of potassium chloride per oral. Next story.
Yes.
This is the 14-year-old pediatric patient with the limit of pediatric and adult, who was in the pediatric ICU for sepsis. The patient was very sick. There was a multidisciplinary ICU team attending to him with an intensivist, and the whole team was there. A decision was made to change the antibiotics of this teenager because the teenager was not responding to the current antibiotics. The pharmacist, he was new to the team, and as all new members, was feeling shy and was feeling afraid because he was surrounded by seniors. And he so happened that he went through the file. And when he went through the file, he saw in the file that previously the child had been diagnosed with multiple drug allergies. The pharmacist wanted to inform the physician, but mentioned it in a very oblique way, was not clear in his communication. The physician did not notice the allergies and gave a medication to the child, prescribed, and the medication was given for which the child was allergic. The child then went into an anaphylactic shock.
Okay, thank you very much, Dr. Habib. So from the last incident of anaphylactic shock, the patient was non-allergic to many medications, but this information was not known to the physician, but none to the pharmacist, actually. And unfortunately, the medication was given and the patient developed anaphylactic shock. So this anaphylactic incident fit which of the safety events that listed in the screen?
I encourage all participants to take part in the poll. The poll is live. We will keep it live for the next minute. Remember, it's anonymous and we cannot see your names. Choose which you think is the best answer.
MashaAllah, this time I'm feeling like they're more engaged in the answers and
yeah.
yeah,
I'm sure these are incidences, though it's good to learn from other people's mistakes, but actually all of us who work in healthcare institutions have seen something similar in our hospitals, actually.
Yes.
Another 30 seconds more before I close the poll. I just want to remind all the participants, don't write the answers in the chat. Please put your answers in the poll. The poll is open. Put your answers in the poll. The chat answers, actually, we cannot evaluate them. Please put your answers in the poll. You have another 15 seconds, please.
Okay, I think fine, Dr. Habib. So we can close the.
Yeah. As per the thing, the majority, 54% think it is an adverse event. The rest are sentinel and near miss unsafe, but the majority think that it is an adverse event.
Yeah, actually, yes, thank you very much. The correct answer here is an adverse event because already he is non-allergy, but this was not caught and already given the drug or the antibiotic, and then he developed anaphylactic reaction. So already there is an adverse event happen. As long as we didn't mention, for example, died or permanent harm, we will not consider it sentinel for the time being. But this is the correct answer. Thank you very much for your participation. I'm seeing that now there is much more engagement for the answering because I think this is now clear going forward. Dr. Habib, you have a comment about this simulation-based learning exercise?
I just want to tell everyone, this is information taken from a recent publication in which they put cameras, hidden cameras, in the pediatric emergency department in the NHS hospitals in UK. And actually, the doctors and nurses did not know that there was a video camera there, though there was a lot of attention to ethics and patient privacy. What they wanted to evaluate was during real courts or even in mock courts, what happens for the emergency medications which are actually told. So in a court, as all of us know, most of the orders are verbal. So there will be a verbal order of give adrenaline, give this medication. So when they evaluated the video recordings for these courts, they found out that almost 1 in 3 medications actually never reached the patient because it was just lost in the noise and chaos of a code. So having proper communication is very important in saving lives, because if an adrenaline is not given during a code, we are going to lose a patient.
Yeah, thank you very much, Dr. Habib. So this was the heaviest part in our webinar. We will go to the another interesting part, which is goal number 3, improve safety of high alert medication. And actually, this is one of the topics that really need to be addressed, because all of us, we are dealing with the medication for certain time, even as a patient, we are receiving these medications. So it's very important to know about the safety precautions for this, as long as they benefit us, again, can help harm us as well if not used properly. So why we are telling high risk medication? Why the name of high risk medication? The medication itself is not risky, but the point is that if given in error, it will cause a risk. For example, insulin is considered high risk, but if you give insulin for non-diabetic patient, it can be a hypoglycemic coma easily. So this is why some medication, the error should be 0 error. Error is not accepted. So these kind of medications that I listed here on the screen for the high risk, neuromuscular blocking agent, thrombolytic, narcotic, opioid, chemotherapy, vasopressor, anesthesia, sedation medication, biological agent, oral hypoglycemic agent, all these medication are considered high risk medication and should be used in caution. Number 2 that we are going to highlight is LASA, or look alike, sound alike. It's acronym. Again, so if you see these 3 bottles, the same medication, the difference is in the concentration. So 1%, 2.5, and 0.5%. So see how look like when you are busy, heavy word, high volume patient, easily can mistake and can be exchanged. So this medication called look alike or sound alike, these also need to be used in caution because error prone medications, and we will address for each one of them in the coming slides. The lastly is a concentrated electrolyte. Concentrated electrolyte, again, it is considered a part of high risk medication, but usually should be removed from inpatient unit. The use is limited for the critical care area, and where also with control access. So should be done in the IV room in the pharmacy, better than keeping it in the ward, as this is a part of safety precautions, because we don't want to be available and ready to use for everywhere. Otherwise, it will be error prone incidents. So let us focus on high risk medications. Number 1, if you see one rule, limited access to the high risk medication. If you see, this is a looked box. We are keeping the high risk medication there, and it should be double locked. Double locked not mean that you will put two keys or to lock the box. Rather, for example, you have double access for it. For example, the room outside is closed, the medication room, and then inside this box is closed, or any other place, but have limited access and lock, so nobody can access it easily. The other thing you can see using auxiliary labels. If you see these all boxes with a red color, this is high risk medication, but not only the boxes. If you see each single ampoule also should be labeled, because once it is gone outside this box, We don't know if it is high risk, but keeping the visual cue or alerting that this is high risk need to be used in caution. Also, for example, electronic medical record. If you are prescribing this high risk medication, automatically the system already programmed to alert the physician that you are prescribing now high risk medications. So all these visual cue system change are done to avoid the errorness during, especially when during busy schedule can lead to error. Other additional precautions, like for example, when dispensing by pharmacy, this kind of medication need to be double checked. And when we said independent double check, not mean that you are going to check the medication 2 times. Independent double check, that means there is one and the other one counter verifying the order. So there is 2 practitioners are confirming. So dispensing, double check. So imagine how many checkpoints you have before this medication going to the patient. If prescribed by a physician, again, the nurse will sign, and there is a counter signature as well. Also during dispensing, for example, she received it from the pharmacy, and then you will find, depend on the hospital policy, but usually countersigned by charge nurse or head nurse according to the hospital policy regarding the verification. So you will find 2 signatures when you are prescribing or administrating these drugs, not only during dispensing. So all these checkpoints are done to avoid any error. So the error can be discovered before reaching the patient. There are many checkpoints that go through this one. Okay, so this is about high-risk medication. Let us talk about look-alike, sound-alike. One of the examples highlighted here is dobutamine and dopamine. This is actually high-risk plus sound-alike medication. So when you are pronouncing or you are writing it, especially if you are using handwriting, easily mistake between dobutamine and dopamine. So one of the things that if you see, they are using tall man letters for the names that is not similar. For example, amine and amine is similar, but dobuta and dopa written in upper tall man letters, not like lower case letters. So this is kind of your eyes, you can differentiate between the 2 easily. And there are many other precautions, like for example, you cannot put 2 similar boxes beside each other, even if the some pharmacies, they are using alphabetical order to arrange the medication, and this is very dangerous practice. So usually if you have like this, you have 3 shelves, so you can if similar look-alike medication, so you can separate the shelves. So if you have one look-alike at the left upper corner, you can put the other one in the counter side and the right corner. So this is a cross sign that to avoid error by error to take this one instead of the other. The other point, if you have like refrigerator but limited space, you don't have much, and you have 2 medication look-alike, so you can separate these 2 medication by 2 to 3 boxes. So it will not be close to each other, and should be as well using a special auxiliary label according to the hospital policy to select which color you want to use for this one. So this organization is in yellow color and highlighted. So this will be a visual cue as well, that be careful, this medication, there are look-like medication like it, and need to be addressed. The same for the system. So when you're writing look-alike medication or sound-alike, you will find it in the system program, because each hospital need to have a list of look-alike, sound-alike lists. So this will be communicated and available everywhere. No telephone order allowed unless if in extreme situation that is described. So limiting the telephone order for this kind of medication, because easily can be mistaken. If you take the correct information, you can, once you reach the shelf, you can, I don't know, but it will happen, like you take another one. So be careful when you are dealing with such kind of medications. Very important to mention that continuous education awareness for the practitioner is very important to keep them all the time alert and aware about these kind of to avoid or to reduce the error can be happening from such kind of medications. I will let you with Dr. Habib to share with us the incident that related to the LASA and thank you,
Okay,
Dr.
thank you, Dr. Basma. Yeah, in the next few slides, we will just go through some mistakes which are happened when IPSG 3 is not implemented properly. What you see photo here is the photo of the CEO of a very famous hospital chain. This is the Methodist hospital chain in the United States, giving a press conference and apologizing because many newborns died in the neonatal ICU of this top of the line hospital, JCI accredited hospital, because it so happened that after putting the cannula, the practice in NICUs is to give Heplock, which is heparinized saline. But instead of giving heparinized saline, they were given full-fledged concentrated heparin injections. The moment heparin injection was given IV, the babies developed an intracranial hemorrhage, and many died, and the many who survived ended up with long-term neurodevelopmental sequelae. The next slide. All this happened because these two heparins, the one on the left, the dark blue one is an heparin 10,000 unit per ml, and one on the right is an Heplock, which is 10 units per ml. It was supposed to be Heplock in the drawer, but it so happened that heparin went in the drawer of the NICU, and someone took the heparin from the drawer without actually reading it, because they thought this is always Heplock and it looked the same, and they were in a rush, and they took 1 ml of heparin thinking it to be Heplock and flushed it and giving 10,000 units of heparin to a baby who weighs 1 kilo. Next slide. These are some very sad stories taken from the AHRQ website. This is a photo of a 79-year-old elderly dialysis patient who, after a dialysis session, had breathlessness, so was shifted to ICU for observation. He had some upset stomach, so the doctor prescribed an antacid, but instead of an antacid being given, the staff nurse by mistake injected him with pancuranium, which is actually a paralytic agent. The patient immediately went into respiratory arrest and died. Next slide. This is just a visual cue to remind us that they look very similar. Maybe now that you're sitting in front of your computer screens, you can read it clearly, but in a busy day in the pharmacy or in the ICU or in the ER, these two can be easily mixed up. Next slide. Yeah, this is another very sad story of a patient who came to the ER and after being evaluated for some pain was discharged home after being given 10 milligram of morphine. Actually, that was the order which was written, but the patient did not get 10 milligram of morphine. He was by mistakenly given 10 milligram of hydromorphine. Please remember that hydromorphine is 7 times more potent than morphine. And once the patient took hydromorphine and he started his journey home, on the way home, he developed respiratory arrest and could not be revived, and he died. Dr. Basma?
Yeah. So which safety event is considered for these two scenarios of newborn and for this hydromorphine error for LASA medication that lead to patient death?
Can I remind all participants that we will open the poll only for 1 minute. Please do answer in the poll. Do not put your answers in the chat. We will close the poll after 1 minute. Please encourage everyone to take part. It's an anonymous poll and we cannot see your names.
MashaAllah, tabarakallah, we have very excellent people targeting, mashallah, the answers.
Yeah, mashallah.
Yeah, mashallah.
For the sake of time, I will close the poll and I will share the results. The majority, 69%, thinks that it is a sentinel event. What do you tell, Dr. Basma?
Yes, excellent. As long as there is already death happen to the patient, so this is sentinel, irreversible, and unfortunate for those patients, but really this scenario can be happening everywhere. So we need to keep reminding ourselves about the safety of these kind of medications. Thank you very much. We will go quickly for the rest of the talks because really we are hitting the time. So we will just highlight the important things for the IPSG 4. This is one of the things that we need to make sure that exists in each organization to comply with WHO recommendation for universal protocol for identifying correct patient, correct procedure, and correct site. So very important, we need to address the surgeon habits. Surgeon habits, for example, the consultant or the senior surgeon, sometimes they will first time to see the patient inside operation theater. And this is really the point that we need to address, that the preoperative patient verification is very important. Preoperative site marking is important, and time out before the procedure. These are the kind of checkpoint that we ensure where the correct patient, correct procedure, and correct site is going on. If we're talking about site marking, and this is want to be addressed, the one who will do the site marking is the procedurist or the surgeon who will going to perform the surgery. It should not be done by the trainee or by the resident or by the junior. The one who will do the surgery, he is the one he will do the site marking. Number two, the patient should actively involved in the marking procedure. For example, you will ask the patient the operation on which part or where your operation will be, on the right hand or left hand, should be clearly involving the patient. And then standard marking process in the hospital. For example, this organization using arrow sign, the head of the arrow pointing to the organ that intended to operation. Site marking is recommended for any organ that have bilaterality. For example, you have right and left eye, right and left limbs, or multiple structure, for example, fingers, toes, or even the ribs or spines. So you have multiple levels, so need to be site marked. Regarding the timeout, a timeout is this is a universal checklist adopted from the WHO, and this is most of the organization they are using, NHS and even in Sibahi and other accrediting organization, they are recommending this safety checklist. Any non-compliance or non-correct happening in any of these checklists can lead to again sentinel event very easily. I will, if you see the timeout, this is the moment that where all we will stop after the induction of anesthesia, the patient completely anesthetized. This is the only part where the patient will not participate in the identification process. He is in the theater, anesthetized, induction before the surgeon putting the knife or the incision on the patient. Should be this a moment of pause or stop period where all the team, anesthetist, nurses, surgeon, will confirm the right patient, right procedure, right site before proceed to operation. And this is the most critical part that everybody need to comply with, because this is the most, otherwise we will end by wrong operation for wrong surgery or wrong patient. And then before the after finishing the procedure, there is before leaving OR, there is sign out. Here is very important to mention that any non-compliance of this, the practitioner has a right to stop the surgeon and to stop everybody and make hard stop. So we need everybody to speak up. If you have non-compliance for this kind of standard, you not pass it as it is, because it can cost the life of the patient or the limb of the patient. Dr. Habib, can you give us an incident happen for OR?
Yeah, actually, if you do a PubMed search for wrong site surgeries, one of the most painful case reports that you can read is a wrong eye surgeries. And most of the time, if you read the case reports, you will always find that the ultimate error, you can tell the root cause, was something to do with the culture and the attitude. It's always the surgeon who is in a rush, who is usually a senior surgeon, who is always in demand, who has a lot of cases waiting for him, and who his peers are afraid of, and they're afraid to talk to him or question him, and ultimately ends up with a wrong surgery. And some of the most painful surgeries mistakenly done is enucleation of the wrong eye. And you cannot imagine the pain. It's not only the patient, but also the treating team will feel. There's a whole book on it, which is called Waking Up Blind, which highlights mistakes of wrong sight surgery. Next slide. This was a case report in AHRQ about an orthopedic surgery, which was supposed to be happening on one knee, arthroscopy, but they mistakenly opened the wrong knee and started the arthroscopy, but they realized the mistake. Immediately, they stitched it up and went back to the right knee. But still, it ended up with a lawsuit because there was damage to the meniscus, the cartilage. Next slide.
So, which incident safety event is considered for incident of operating on wrong limb?
The poll is open.
Yeah, 30 seconds only, Dr. Habib, because of the time.
Okay. We encourage all participants to take part now. This is an anonymous poll. The question is, what type of safety event it is if surgery took place on a wrong limb? Okay, for the sake of time, I will be closing the poll now, and I will be sharing the results. And Dr. Basma, the majority think that it is a sentinel event. What do you tell, Dr. Basma?
Yeah, actually, excellent. Any wrong operation is considered sentinel event, even if the event didn't cause any death or maybe no permanent harm. For example, they did the incision and then they close and then they open another one. Again, considered sentinel event because this should be a never event, should not happen aslan to have operation on the wrong side. So this is considered sentinel event regardless of the outcome. It's considered sentinel event even if there is no death or major loss of function. Thank you very much for participating. Let us going through quickly for the IPSG 5, reduce healthcare associated infection. Just one thing for this patient safety goal, which is hand washing. And this is a universal protocol by WHO, 5 moments of hand hygiene. You will find it in everywhere posted and hang it, but I'm sure we need reminding ourselves every time to wash our hands. Washing hand, we can save the life. If you see the healthcare associated infection, any infection developed for the patient hospitalized within 48 hours of admission or after discharge by 30 up to 30 days post-discharge, considered healthcare associated infection. For example, you operate in the patient, cesarean section or whatever, she developed infection after 14 days, wound infection, it will consider healthcare associated infection. And if you see the statistic is very huge, 1.7 million hospitalized patients annually acquire healthcare associated infection, and 1 in 17 patients die due to healthcare associated infection. So compliance for hand washing, simple hand washing technique, we can prevent a lot of adverse event and even save our patient life. And these are the studies showing and addressing also continuous education for the provider reduce the risk of infection by 40%. And this is really very important to address. I will go through quickly, Malish Dr. Habib, for the last international patient safety goal number 6, which is reduce the risk of harm, because I'm sure this infection prevention team can cover most of these and majority, and we can make another webinar for that. But really, our focus today about patient safety goals. And lastly, but not the least, full prevention. In the GCI standard, it's mentioned about inpatient, about OPD, and about how to prevent the risk. And by having environmental risk assessment and compliance with the side rail for the bed, lowering the bed maximum to the floor, near to the floor, so the patient will not be slipped. And there is two incidents like about patient want to just to charge his mobile, and then he slipped over. So make sure that there is switches and everything available for the patient. The washroom should have a button or a bell, so can assist the patient who are really in need. Very cautious for patient taking medication. And in addition to that, using the visual cue, wearing special bracelet for those who are having high risk of fall, and labeling of these things need to be addressed. These are the full risk assessment tool utilized by most of the organizations, adopted for adult, more full scale, for pediatric Humpty Dumpty. The idea, this should be done in every shift, once a shift, or if there is a patient changing in patient condition, for example, level of consciousness disturbed or whatever, or transferring patient from one unit to other unit. All these we need to have risk assessment repeatedly done again and again to ensure that the safety of the patient is our priority.